Hello again, and welcome to OU on the Road, a virtual road trip. I'm Catherine Lehman, your moderator for this evening. Why do we call this series On the Road? The majority of our OU alumni, retired staff and faculty, and friends of OU reside in Southeast Michigan. However, we have a large contingent in Florida. And each year, the president goes on the road to our friends in Florida, bringing faculty presentations to enrich the guest experiences. So due to COVID, we couldn't travel this year, and we created this series of virtual events, so a virtual road trip. We hope you enjoy all the presentations offered this week. Dr. Deidre Hurst will be our guest speaker tonight. Dr. Hurst will be taking questions following her presentation. To submit questions, use the Q&A icon at the bottom of your screen. Put in questions anytime during the presentation, and she'll address those following. When we have a presentation with a guest speaker, there's a reminder that we always give, and it is the views and opinions expressed in this program are those of the authors and do not necessarily reflect the policy, the official policy or position of Oakland University. Oakland University fully supports the First Amendment. So I'd like to introduce your host for this evening. Aaron Sidrovich is the Director of Alumni Relations and joined Oakland University in 2005. Beyond managing the alumni team and its initiatives, Aaron is highly active with the Michigan Relations Professionals Organization, and in December 2019 was selected to serve on the leadership cabinet for the Great Lakes region of the Council for the Advancement and Support of Education, or CASE. Aaron, I see you're with me.
Hello, how are you, Catherine?
Welcome, and take it away.
All right, thank you so much. And good evening, everyone, and welcome again to OU on the Road, a virtual road trip. And tonight's session, Choice and Circumstance, Understanding Social Determinants of Health. As Catherine mentioned, my name is Aaron Sidrovich. I'm the Director of Alumni Engagement, but I'm also very pleased to be joining you tonight as your session facilitator. So without further ado, I would like to introduce our faculty presenter, Dr. Deidre Hurst. Dr. Hurst joined Oakland University's William Beaumont School of Medicine in August of 2020 as an assistant professor in the Department of Foundational Medical Studies. She teaches medical students about health promotion, health-harming social determinants, and practical applications of public health principles. Dr. Hurst has interdisciplinary background in both academic and executive leadership. Her research interests include health equity, social determinants of health, and communicable diseases. In addition to leading the Michigan Community Health Worker Alliance, she has leadership experience in health center operations and enabling services. Dr. Hurst is also an active member of the American Public Health Association and serves on the Michigan HIV/AIDS Council. So without further ado, may I now present to you Dr. Deidre Hurst.
Thank you so much for that introduction. I am excited for the opportunity to talk with you today about choices and circumstances that affect health outcomes. As a professor in the Department of Foundational Medical Studies, every day I get the privilege of working with some amazing students who are well on their way to becoming excellent practitioners that understand medical science and the social context of health in America. Where you live, work, learn, play, and worship have significant impacts on your health. These social determinants include things such as exposures to toxins, risk of violence, access to jobs, and healthcare. While these factors are widely known to impact health, most people underestimate the impact. Social determinants of health can impact clinical outcomes substantially. Considering the complexity of the social factors like homelessness and crime, it can be hard to identify who's responsible. The healthcare system alone cannot be expected to heal our country of all its social ills. But the lines of responsibility are blurred. Maya Angelou once said, "Do the best you can until you know better. Then when you know better, do better." Research shows us that medicine has to go beyond the pill and find ways to collaboratively respond to and address social determinants of health. When I talk to people about what factors influence health, generally, there's an assumption that healthcare has the largest impact on health outcomes. And when you take a look at healthcare spending in our country, it's not hard to understand why people would think that. Our students at OUWB have a rigorous curriculum, so they get the hard science, but they are also exposed to factors that influence health outside of the exam room. We prioritize this because research tells us that there are 4 primary factors that shape a population's health. Healthcare is only 20%. 20%. And when I say healthcare, I'm mainly talking about access to quality care. Now, 30% of the equation is health behavior. These are choices that people make. So, do they smoke or wear a seatbelt when they drive? 10% is the physical environment. So, is there air safe to breathe? Is there water safe to drink? And the largest impact on health, making up 40% of the equation, is social economic factors. Are they educated, employed, poor? Perhaps you've heard that good genes are what lead to a healthy life. However, in 2014, public health researchers determined that zip code is a better health predictor than genetic code. The Robert Wood Johnson Foundation has a nifty web tool that will provide life expectancy data based on county. You just put in your zip code and you get the most recent data. I put in 2 neighboring counties separated by a street called 8 Mile. For those of you with Michigan roots, 8 Mile is a street that should resonate with you. As you can see on the slide, Wayne County citizens have a shorter life expectancy. It seems irrational that someone's life expectancy could vary by 5 years depending on what side of 8 Mile they happen to live on. We know that a physician isn't likely going to impact where their patients live, but they can and they should know what life is like where their patients live. And who better to inform them than the community? I'm a believer that you can't truly appreciate a person's resilience if you don't know their story. Understanding the collective story of a community where a provider practices helps to shape how they think about the people they serve, and it helps to reduce bias and judgment that is often the culprit of mistreatment. One of the threshold concepts that I teach about and use as a guiding principle for research is wellness is not the absence of disease. Once students understand that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, it can be transformational. It takes the focus off just fixing the person and allows for critical thinking and developing responses to health disparities that include the lived experience of their patients. Don't we all deserve to live happy, fulfilled lives? The reality is, the opportunity to live happy and healthy is not the same for everyone. Our country has some serious health disparities. And when I talk about health disparities, I'm referring to gaps in health that reflect differences that are so large they require our attention. A health disparity is a higher burden of illness, injury, disability, or mortality experienced by one group relative to another. A health care disparity typically refers to differences between health insurance coverage, access, and quality of care. Considering the current COVID epidemic, we don't have to look far for examples. We have all seen the news about how COVID-19 impacts people differently. It's a lot harder to isolate if you live in a multi-generational household, or practice safe hand washing if you don't have running water. Some differences affect people who do not have any control over their choices or their circumstances. For example, infant mortality is a disparity that has been woven into the American experience for a long time. In 1935, mortality rates in general were high in our country, but babies were dying at an alarming rate. Over 55 babies died for every 1,000 live births. We decided that was not okay as a country, and we worked to improve mortality rates for everyone, including babies. By 1980, the infant mortality rate was 12 deaths to every 1,000 live births. By 2018, we saw just over 5 deaths per 1,000 live births. However, the rates of improvement were not consistent for all babies. The data reveals a troubling story of difference. Blacks, Pacific Islanders, and Native babies are more than 2 times as likely to die than other babies. Researchers like me see the data as an opportunity to keep working to reduce the total number of babies that are dying, and an opportunity to narrow the gap of infant mortality between racial and ethnic groups. But please understand, the health disparities are just one way to measure our progress toward achieving health equity. That leads me to share exactly what I mean when I say health equity. This principle is based on equality, fairness, and justice. Inequities are created when barriers prevent people and communities from achieving wellness and living up to their full potential. Teaching and researching in this field is so critical because we all benefit when we have healthy communities. I believe health is a human right. Life, liberty, and the pursuit of happiness, those inalienable rights declared by our forefathers, have been given to all humans by their Creator. We know from the data that wellness is not equally attainable. Since we know better, we should do better. Introducing and teaching about the impacts of social determinants of health is not enough. Actually, there was a recent study that said just learning about social determinants of health doesn't reduce health inequities. Our future physicians and practicing physicians alike grapple with concepts like the intersection of poverty and poor health. Introducing and teaching about the impact of social determinants of health is not enough. Actually, a recent study argues that just learning about social determinants of health doesn't reduce health inequities. Our future physicians and practicing physicians alike grapple with concepts like the intersection of poverty and poor health. That's why research that examines health behavior, choices, and social determinants of health circumstances is so important. And while I've made the distinction between choices and circumstances, I want to reiterate that there is a connection between the choices people make about health and the circumstances of their lived experience. As part of a training in foundational medical studies, students learn about how to influence health behavior. In a course that I co-direct, students are exposed to topics related to behavior change, and they have a service learning component of their course that exposes them to the social and economic factors that influence health. I want my students to learn about and appreciate both quantitative and qualitative data. I tell them that they need to know and understand the numbers and the words. For example, I did a study in 2019 on adolescent substance use, and we found that trauma like physical fights, rape, intimate partner violence, and even bullying were significant indicators of risk for adolescent heroin use. And we came to this conclusion by analyzing data from national surveys. But we confirmed what we learned from the numbers by talking with people who misused opioids. We listened to their stories, and I tell you, both sets of data are equally meaningful. We can't get to the solutions of health inequities without knowing the story of the communities that suffered the most. Medical students exposed to the community through service learning and research benefit from their experiences, and it is likely that their future patients will benefit as well. On a very crisp day last fall, some students and I went to a local homeless shelter where they were receiving a group orientation for their service learning. Due to COVID, we were seated outside. It was frigid, and we were there for about an hour. None of the students complained, because during our time there, the director asked them if they could put together a health education presentation on how to avoid frostbite. You see, as we sat there, cold, inconvenienced by masks and social distancing, they had to think about what it was like to survive a Michigan winter homeless. They didn't complain because they were overwhelmed with empathy, wondering what someone who was freezing outdoors in the winter could do to protect their limbs from frostbite. Educating students is my privilege and my priority, and involving them in research that includes the community is my passion, because it helps them to understand the challenges and gives them opportunity to consider viable solutions to community issues. The opioid crisis in the U.S. is a perfect illustration of how systems are connected to health. Many studies have connected the increased availability of prescription opioids with provider prescribing patterns, meaning that doctors writing prescriptions for pain meds played a significant role in the epidemic. That information has informed policy change and changed the behaviors of the providers. People that were introduced to opioid dependency because of a prescription told their story and helped researchers to understand pathways to opioid addiction. Their stories informed the development of current prevention efforts. I'm a part of a group of OUW faculty recently asked by the state to conduct key stakeholder interviews with foster parents investigating barriers to substance use disorder treatment for Medicaid-eligible youth in their care. These types of opportunities help us to involve students in system-level approaches to addressing health disparities. Additionally, these type of projects rely on community co-investigators that help define and address the problem. On this slide, you see the principles of community-based participatory research, CBPR. I'll pause and give you just a second to read them. Introducing students to this type of research helps them to identify problems with the community rather than prescriptively informing the community what's wrong with them and what they need to change. This type of research helps experts listen and hear, enabling them to bring their acquired expertise to solutions of the problems that the community is willing to invest in. As much as I can, I engage in this type of research because I feel it is the best way to identify and develop plans that respond to health-harming social determinants. For those of you who are not familiar with CBPR, it's research that recognizes the strength of each partner. The community is involved as an equal partner with the researcher. This helps ensure that interactions created are responsive to the community's needs. It's not just research for the sake of research. It's research aimed at solving problems the community helped to identify and prioritize. I hope to be able to continue to do this type of research at OUWB and look forward to finding ways in the future to keep our students engaged with the community. Thank you for your time. I look forward to answering any questions you may have, and I have to end in true OU fashion. Go Grizzlies!
Go Grizzlies indeed. I would now like to introduce Dr. Deidre Hurst to join us live and in person. There she is. How are you, Dr. Hurst? Can you hear me okay?
Yes, I can. I'm well. Thank you.
Thank you so much. That was fascinating. There's so much going through my head right now after listening to that, especially given the climate that we're in right now. You know, it's so timely, it's so relevant, and I'm just so glad to be able to have a few minutes to connect with you and to get to some of our audience questions. So thank you again for joining us. I think we're going to dive right in. Actually, we've got some questions that have been coming in during the presentation. And what a couple people saying they love the phrase, when we know better, we should do better. I think that's a wonderful mantra to hold on. But one of the things that was asked initially from an anonymous attendee is, how is OUWB addressing social determinants in the classroom? Can you speak a little bit more about that?
Yeah, absolutely. I think there's several elements in our curriculum that touch on social determinants of health, but in particularly, I can talk to the course that I co-direct, which is Promotion and Maintenance of Health. And in that course, there are specific lectures that are attributed to social determinants of health. There's also a service learning component. So we actually get students in the community, get them to understand some of those challenges and issues that the community is dealing with. So it helps them to develop their own understanding of the problem and not just have it being something that's told to them. It's been a little difficult with COVID, but I was just on a community call earlier today, and they were sharing about how some of our students from the med school were volunteering, just tutoring children that are in like middle school and high school. And you may think, you know, how is that connected to medicine? But when they're there and they're mentoring those young children and having that experience, they start to build relationship. And for me, I think that to address social determinants of health, you have to have a relationship.
Absolutely. And actually that ties into another one of the questions that came up here. Do OU medical students get hands-on experience with varying types of individuals from different socioeconomic statuses? Maybe you can talk about what they're doing now, given the COVID environment, but even what's been done in the past or what we're looking forward to in the future.
Yeah, you know, I'm relatively new in my role. And, you know, as I said, having that opportunity to get students in the community is something that I really appreciate. And I hope to be able to really strategically identify different populations where students have opportunity to volunteer with service learning. We also are very strategically introduce different experiences of different populations in our teaching. We have a section that talks about the history of African Americans in medicine. And there's other opportunities in the curriculum, particularly in humanities, where they talk about different populations and get that exposure. But in all transparency, I think, we do have opportunity to grow. And that's what we aim to do, is to get better and create more space for students to have exposure to different populations and opportunity for them to actually, learn about and not just have the superficial, but really get, experience talking with people.
Sure, digging a little deeper, right? It's beyond the theory into the practice, right? And ultimately, that's going to make them a very well-rounded physician. Then, I think that's a hallmark of OUWB. So that's great. There's so much going on there every time I hear about the medical school. One of the questions that came in regarding medical school from another anonymous attendee, besides medical schools teaching med students to identify and develop plans to address these kinds of problems, what other agencies are working on this type of work?
I mean, in terms of just working on social determinants of health, I think there's lots of community-based organizations that are doing this work. I mean, the health department is involved. You have policy that's involved. For me, I think it's important also to make sure that students have access to research in this area, right? So that they're able to take the research principles, the things that we teach them about population health, and then go out and come up with their own research questions.
Mm-hmm. Speaking of questions, I do want to offer another reminder to everybody to please go ahead and put your questions in the Q&A. Just use that Q&A icon to add your questions in, and we'll get to as many as we can. Nancy writes, can you talk about the importance of including the CDC's Social Vulnerability Index in the process of distributing COVID vaccine in Michigan, rather than just distributing vaccine on per capita income and age alone? Thanks, Nancy, for that question.
Yeah, when we hear about vaccines, there's lots of things in the news that talk about vaccine hesitancy and, people not wanting to take the vaccine. However, there's a lot of people who want the vaccine and it's just not available to them. And when we think about how COVID has impacted populations, particularly African Americans and persons that are Hispanic, they're dying at higher rates, yet there isn't procedurally wise ways to get them the vaccine, making it more available to them. I'm from Flint, grew up in that area, and it just seems like areas like Flint, when you have the water crisis, you have all of the things that came along with COVID, and I still see so many people in my family, people that I know that really want the vaccine but can't get it. So I think it's important to consider, what people's risks are, certainly based on age, but also, where's the virus more prevalent, and, are there some other factors that could be considered?
A lot of people have talked about this time in our lives. I mean, I can't tell you how many times I've heard the phrase, we're building the plane as we fly it, right? Do you think that, a silver lining that may come out of some of this is that we will be better prepared in the future to handle, the unique, inequities? Well, not even unique, but I mean, those inequities as we move through other issues, hopefully not another pandemic. But I mean, do you think we're going to learn from what we're working on right now?
I hope so. Yeah. I hope that when what we have seen with COVID is that lots of people are producing articles and there's data that supports it. Dr. Khaldun at the state, she has really made sure that we're able to capture things like racial disparities with our COVID data. And a lot of states don't have that information. So they don't know, they can't show the disparity because they don't have the data.
Yeah, actually, that was going to be my follow-up question. I mean, how are we doing in Michigan? I mean, do we seem to be leading by example, or are we kind of following along? I mean, what are your thoughts on that?
Well, in terms of health disparities, I think there are some very critical disparities that Michiganders need to do better at, right? I mean, we have really high infant mortality rates, and the COVID disparity I just talked about. And there's other disparities in Michigan I think that we can improve on, but I do think that we have the will to do better. We have some really strong statewide support to address, some disparities. And I feel like we're having the right conversations. We just need to start putting some things into action.
Yeah, the pieces are there, right? Let's tack them together in the most positive way that we can. Absolutely. You just mentioned infant mortality. I know, that definitely that was very interesting to see those slides and hear you talk about that. Certainly blew my mind. I was not expecting, those numbers and that information. What ideas do you have about what can be done to further address that issue?
For infant mortality, what comes to mind is just support, right? Families need support when they're expecting, and they need that support before the baby comes and until, a year out, right? And one of the things that I think is important is getting them connected with those community supports like community health workers, doulas, peer support specialists if they happen to need one. Having those type of supports during pregnancy and postpartum are very, very important. And I know that some other states, they have funding through Medicaid that supports doulas. And I think that, Michigan is moving toward that direction of being able to find ways to, pay for and actually encourage women to engage, or in families to engage with those community supports.
Yeah, it's almost like there needs to be a menu of opportunities available, because you have to think about what's going to fit best with that individual or that family and where they are in this socioeconomic status spectrum, right? And even all the other factors that come in that make, the lens of your life as you move forward.
Yeah, I mean, we have excellent healthcare facilities, but if you can't make it to that facility, if you don't understand how to navigate the healthcare terrain or use the benefits that your health plan offers you,
yeah,
it's challenging.
Right. Absolutely. I mean, you're seeing it even now going back to COVID, so many people are having so much of a hard time just figuring out when they can get a vaccination or where they can go. And I mean, if you can't sit down at your computer for, a few hours a day and get yourself signed up somewhere, that's hard. So you think about that. You got to have a computer for one. You got to, have internet access. You need a car to get there. I mean, all of these things factor in. And it makes it seem like it's a pretty big lift, right? But to that end, we did have a question about collaboration, right? So how do we lift together? Could there be a collaboration between, even here at OU, the School of Nursing, the OUWB School of Medicine, the Health Sciences, School of Health Sciences? How can we work together, to look for points of similarities in the programs and address these health disparities? What are your thoughts on that?
Interdisciplinary work is critical. Actually, one of the mandatory sessions for my students is a interdisciplinary event that we have on campus with nursing, with public health, and even physical therapy. And we talk about opioids and how to, address the opioid epidemic. I think that, community is so important. And one of the ways that you actually build collaboration is just by being present, and it's been difficult during COVID to, stay present in the community. But I think that researchers that are there when a problem arises and the community is concerned about it, when they have a researcher that doesn't just show up, when it's a crisis, but has kind of been there all along and involved. And that's how you really get to the solutions of some of these problems.
We actually had a question here. How can we engage together in our health promotion class in both the School of Nursing and OUWB School of Medicine? Do you want to talk a little bit about the health promotion class? What is that?
I'm not sure specifically what the health promotion class is, promotion and maintenance and health, the course that I teach. I'm happy to, collaborate and work across campus and work in the community and help, come up with new ways. I think that, dialogue is our best strategy, right? If we can just sit down, have a conversation, and come up with ideas about how to get our students working together and collaborating on things, I'm very open to that.
Yeah, let's talk about that student experience. I know there was a question in here about this came from Nancy. What are some of the most challenging questions your medical students ask you in class about these issues?
Yeah, they don't ask as many of the intimate questions now that we're in this virtual environment.
Yeah.
But I think where students may struggle the most is, they may be well intended and they have the best intentions, but how do they balance their own unconscious bias, right? When those things that come up and you're not even aware of them, or you happen to maybe misgender someone or say something offensive, like what do you do then? And so, I think helping students to understand that we're all human, we all have bias. We actually have a session on unconscious bias
I've attended it. I know what it is. It's fantastic. Yes.
I think getting them to understand that it happens, but what do we do then? How do we mitigate that bias? And how do we respond when we see bias in our policies and in our organizations?
So I want to dig a little bit deeper into something that you mentioned in the session, the presentation, about listening to stories. I thought that was really powerful. And it kind of goes back to some of that relationship building, right? We talked about earlier. How do you teach future physicians to listen to stories? How does that work?
I think it's they get a lot of information about how to take histories. And one of the things that is important for me to stress to them is that you're not just, you have to be cognizant of what's going on with the patient. You need to be quick in thinking, but you also have to realize there's a human being in front of you. And that human being may be at the worst time of their life, right? They're showing up in the emergency room. And so it's being able to balance that machine thinking, right? That I need to assess, process, but also see the person that's in front of you. And one of the ways that we can do that with research is by doing qualitative research, gathering the stories, and then presenting those collective stories to people so that gives them some understanding of impact at a level that maybe they don't have the time to kind of gather all of these stories on their own.
Yeah. And really, I think that was kind of what I was thinking about, was they're taught so much science, it's the hard science, and yet you're dealing with people and emotions and, backgrounds. I mean, all that. Really, how do you best balance that, as you're teaching this individual to become a well-rounded physician, right? Similarly, the slide that you had put out that had equality, equity, and justice, and the three people watching the sport. I thought that was really a very impactful way to showcase those three concepts. How do you weave that through your classes, and to kind of to ensure that the students are understanding what that says, what that means, what that means for them as physicians, right?
Like I said, it's really a threshold concept to think about. Wellness isn't the absence of disease. And to achieve wellness should be something that everybody has access to. What is someone's barrier to wellness? And whatever that barrier is, we need to figure out how to remove it. It's not, I think about, the imagery of having the fence completely removed, and how we have all the resources in our country. We have all the knowledge in our country, we can remove the barriers, but it's going to take systemic change, and it's going to take, people wanting and having the will to do that. And so, I get to work with second year students who haven't even gone to their clerkships yet. So I hope that I can plant some seeds about, justice and fairness and equality, and help them to start to think synthetically about what that means, so that when they run into an instance, they're like, okay, I can process that. I've heard about this. I can figure out a way to help remove the barrier for this patient.
Yeah. Along those lines, we got a question that had an example in it. This individual says, I saw today that Mayor Duggan of Detroit is offering vaccines to suburban residents 55 and over if they assist Detroiters who need assistance with transportation to get vaccines. This seems very resourceful. What are your thoughts about this, and what other things can be done like this? So some of that removing barriers concept you just mentioned.
Yeah, I haven't read specifically about that, but I have seen where they, in other areas where they offer the vaccine to a person who's driving or transporting the person who's elderly. And, I think that is an amazing strategy, especially since you're removing the barrier of transportation by incentivizing, and you're also helping to, like, strategy wise, you have to get 2 vaccines, you have to use it within a specific window of time. And so there's some logistic challenges where a vaccine may go unused, right? Like they expect 50 people to come, but 40 show up. And so if you're able to, have those people that are transporting also get vaccines, that's important. And then third, if you live in a multi-generational household, you want to offer protection for as many people in that household as possible.
Broadly. Absolutely. What other things are being done that are making an impact on not even just COVID, but other resourceful things like that you could give as examples of really making an impact on this issue, of these health disparities and things like that?
Well, I can talk about a project that we just recently started working on, where the state received a lot of money to assess substance use disorder treatment for, like, Medicaid population. And we were approached at OUWB to say, okay, who aren't we thinking about? And immediately we were like, young people, you're not thinking about young people. So they supported us in doing a project evaluation where we're going to do some interviews with young people who were in foster care and other people connected to the foster care system to try and understand what those barriers are to SUD treatment, and having those conversations and being able to understand from what happens, what is it like when a young person has a substance use disorder and they're in foster care. And getting that story and documenting it will allow for the state to then say, okay, these are some changes that we should make, and think about policy and strategies that they can take.
Yeah, what support can we create, right? I think, that's amazing. How do you get the community to participate in research? That was a question that we had earlier written in. Are there challenges to participate in research projects? I'm kind of switching gears here a little bit.
Yeah, COVID has definitely made it difficult. But I think that communities they're savvy. They know if you're just coming into their community to publish, or if you're just there to, write a paper or do a project. And so one of the best ways that you can get connected to community, again, be present and be genuine. I think that I like to work with community co-investigators because they have a pulse on what the research question should be. We can't go into communities and tell them, this is your issue and this is how we think you should fix it.
Right.
I think that doing that, it's not only disrespectful to the community, it makes them not trust you. It makes the work that you did to come up with some solutions maybe not be accepted by that community.
Yeah, right. Now you mentioned that you were from Flint, right?
Yes.
Did you work at all with the water crisis in any of that capacity there when that was going on?
Well, it's still going on. There's still
Right.
still like lead in a lot of the areas in Flint. I didn't work in Flint at the time, but I have family that lives in Flint. My father lives there. I live close to Flint. So I experienced it real time, wondering, how it's going to affect my granddaughter, how it would affect, my dad and other family members that live there.
Yeah. We just got another question that came in. This individual says, I commend OUWB for the work they're doing on these issues. What is the best way that we as members of the OU community can help? What can we do to help our students? Do you have some thoughts on that?
Yeah, especially like during this time of COVID, I think it's hard on everyone. And we have some bright students who are really, just trying their best to navigate it. And so, I try to make sure and just give them grace. And then also just, finding ways to engage with the students. They are participating in service even outside of the service learning project. They want to be connected. They want to be active. And so, if there's opportunities for them to be engaged, I would love to try and help facilitate that.
Yeah, absolutely. One of the things that I wrote down in my notes, if you'll permit me to ask you my question, the wellness is not the absence of disease. I thought that was a really interesting way to talk about some of these, subjects. Can you talk a little bit more about what that means? That this concept, wellness is not the absence of disease. What does that mean? What does that mean to you?
So we can't just focus on sick people. We need to focus on how to keep people healthy, how to make sure that they have not only physical health, but mental health, spiritual health, that all the things that are needed in our society for people to thrive are present. And oftentimes we try to, when we think about, health, we're focused on the emergency or the chronic condition. And really, we need to focus on what can we do to avoid the emergency or the chronic condition. And, include prevention. We need to include, opportunities to look at mental health issues the same as we look at physical health.
Right. And that's been coming up a lot, obviously, lately, too. I think there's been a lot of additional attention on that. And, even as you're teaching the OUWB students, how does that concept, like the mental health part of it, factor into teaching, again, and talking about it holistically,
Well, they certainly do spend a lot of time talking about mental health. They have it's in our curriculum where they focus on that, but particularly in our course, it's about, looking at the whole person. And so we try our best to find ways to integrate cases where a person may have a chronic condition and also maybe a mental health concern. And so that with the cases that we present to them are as close to real people as possible. They're not just those one issue cases.
Yes, right. We actually got a question here that just popped up. Have you heard of or met Dr. Mona Hanna Atisha? Do you know that name?
Yes, I know Dr. Atisha. Yes.
Who's that?
She was very pivotal in the water crisis. She actually was one of the first people to say, hey, I see lead she's a pediatrician. And so she recognized that there was an issue. And just a very wonderful woman, very brave. I think that one of the issues that contribute to social determinants of health is that people may see a problem, they may know it's a problem, but they don't say anything. You know, and they're complacent with what's going on because maybe speaking up is too much risk for them. And, you know, she is the perfect example of someone who was very fearless. Like at the beginning of the water crisis, people didn't believe her. She was challenged. But she stayed the course and exposed the problem that existed.
You know, I think we could have another session on that subject entirely. You know, I mean, we could spend another hour just talking through, you know, the ethics around all of that and the challenges and so on. But we are getting close to the end of our hour. So I wanted to set up one last question for you because I think there's a couple of questions in this, but I think this will be a nice way to conclude our time together. We've got a question here from one of our attendees. Would you be willing, Dr. Hurst, to talk about who inspired you to get involved in changing healthcare and improving how we address disparities? And also what organizations, maybe something like Big Brothers, Big Sisters, community churches, have been running effective programs to help their communities most at risk? So kind of a two-part there, but maybe first you want to speak about your, maybe some folks who inspired you.
So initially I started out in social work. I wanted to be a social worker, and I did an internship at an HIV organization in Flint. And I did that internship because I had an uncle who died of HIV/AIDS in the 90s. And I saw I didn't have words for it then. I didn't know it was stigma, you know, but I saw how he was treated differently. And I saw how even the healthcare system treated him differently. And you know, after spending time in that internship in undergrad, I started to be interested in HIV, and I went on to do work in HIV. And that's kind of how the course of my career happened. And I think seeing the world through the lens of persons living with HIV, and that really grounded me because there are so many factors that contributed to, you know, when I was testing people, they would have the same risk maybe as, you know, any other group, but there was high concentrations of HIV within their social network. So it wasn't that they were bad people or behaving any differently than anyone else. It's just that there was a higher prevalence of the virus in the areas where
they were, right?
They were, yeah. So, you know, and it just really grounded me, and it taught me a lot about empathy and about where, you know, where systems can actually make a difference.
Absolutely. And systems and organizations, which is kind of the second part of that question. What organizations such as Big Brothers, Big Sisters, community churches, or et cetera, have you seen running effective programs to help the communities that are most at risk?
You know, I'm relatively new to the Pontiac area. So I've been trying to like get to know some of the organizations there, and being part of the Healthy Pontiac Coalition. There are so many organizations that are just, you know, trying to deal with this COVID, that the issues related to COVID. And they're also, you know, I'm going on a blank to think of a particular organization that I would want to lift up, because there's just so many that, right. You know, after school programs, there's, you know, the churches. I actually volunteered with a church in Ypsilanti early on in the pandemic, and they were doing full like meals, like boxes of food. They had all day assembly line of food. Wow. And they're volunteer based, right? And all the people who are volunteering were mostly older people who were at risk and still masked up and came out. So I don't have a particular organization to lift up because I think there's just so many of them.
Yeah. You know, it's important to keep our eye on work that's being done like that too, right? You know, because we can get so, you know, tamped down by everything else that we're hearing and seeing. but there is a lot of positivity out there for sure. And I think definitely, you know, coming to a conclusion, even with tonight's session, that's a great way to think about it and to get involved in those organizations and to continue to have that empathy and to be caring to our, you know, our fellow human beings here, right? You know, let's exude that humanity to one another right now for sure, and moving forward.
And if people are, you know, interested in connecting with organizations, the My COVID response is still up. It's still available, and there's still opportunities through the My COVID response initiative for people to get involved and find out what organizations are doing what in the community.
Absolutely. I love it. I love it. Well, on that note, we are going to conclude our session tonight. Dr. Hirsch, thank you so much. It was a pleasure to connect with you and talk with you, and definitely to learn from you and hear about your expertise, and to know that you are out there teaching our med students is wonderfully comforting to me. So thank you. Thank you so much for participating tonight. It's been a pleasure.
My pleasure. Thank you so much for having me.
Absolutely. And thank you to everybody who listened to our session tonight, who participated and asked questions. We appreciate that. If you could all hang on for just a moment as we conclude our session tonight, we have a very brief survey that you can give your feedback about other sessions such as these that we want to continue doing. And in fact, if you're thirsty for more, there's one more OU on the Road virtual event tomorrow night with some of our faculty from the School of Education and Human Services. So again, thank you all for a wonderful session. Thank you, Dr. Hurst. We appreciate you. And I hope everyone is well and has a wonderful evening. Good night. We'll see you soon.